you.
All right, we're going to get started.
Okay, let's do it.
Good afternoon, everyone. Welcome. I'm Steve Bishop. I'm the Associate Chair for Education for the Department of Medicine, and it's my pleasure to introduce our guest speaker today, Dr. Kalajian. He is right up here. Unfortunately, there were some weather issues, and his plane from Newark was not able to make it into Richmond on time. And so he hustled back in an Uber to his office and is going to give us our first remote grand rounds here. So Dr. Kalajian went to Touro Medical College in New York and then went on to do his residency and chief residency in internal medicine at Yale University, Greenwich Hospital. And he is board certified in internal medicine and obesity medicine. He is the moderator of the Low Carb MD podcast. And we actually met at Low Carb Denver back in, was it April? April, right?
Yeah,
and,
March, April.
And then we tried to connect to Disney World after that. For all of you who know me, I'm a Disney fanatic, but the timing didn't work out. But I was able to convince him to come give grand rounds. He is in private practice in New York, and his practice focuses primarily on providing direct primary care and on obesity medicine. And he's going to talk to us today about dietary advice and weight loss. All right.
Listen, I'm very honored to be giving this talk, and I was on a plane to come visit you guys, and I'm so sorry I couldn't come. I was literally on a tarmac for 2 hours before they decided to, tell us that the plane needed to be refueled, and I said, you know what, I'm not going to be able to make it. Let me just see if I could get to my office. So it's kind of fitting that we're doing this remotely because a lot of my practice actually is remote management. And we'll talk a little bit about that at the end of the talk. And what I mean by remote management, we do video conferences with patients. So if they need help or they need a little tweak in between our monthly visits, we do that through remote technology just like this. And we monitor blood glucose completely remotely. We monitor blood pressure completely remotely. We monitor weight, body fat percentage, muscle mass completely remotely. And so a lot of what we do is we make it easy for patients. So we help them with their weight management and their glycemia management and their blood pressure management completely from their home. They don't have to send their logbooks or, come in to see us. We are tracking their blood pressure every day, their blood sugar every day. And we meet like this, just like we're meeting now. So it's kind of fitting that we're doing this. So, all right, let's talk about really what I want to get across with this presentation is that nutrition is fraught with influence and bias. Okay, there's commercial interests from Kellogg's, Nestle, Mars, Frito-Lay, Pepsi, Gatorade, Power Bar. Then we have kind of ideologic interests, people who have moral or environmental convictions and are trying to influence what the nutrition literature says. So not only do we have influence from kind of the market and these big companies, these commercial interests, but we also have people who have, certain agendas that they want to see bear out in the literature. And so I want you to question everything that you see when it comes to nutrition. And it's not hard to do that, right? It's not hard to do that because one day eggs are good, the next day eggs are bad. And then one day eggs are good again. So it's not hard to question the observational and epidemiologic data that we see. So the title of this presentation is Questioning Dietary Dogma. And then let's bring it back to the patient. Let's make nutrition about the patient in front of you. And so I'll try to do that today. So my disclosures, again, I'm going to report my personal dietary disclosures. I have failed Weight Watchers and low-fat diets personally. And I found personal success with low-carb diets and intermittent fasting. So I want you to know that, okay? Because there are scientists and researchers out there who try to maintain an element of neutrality, and yet they have personal biases that they don't disclose, okay? I work in a practice that promotes low-carb diets, okay? And I'm a co-host of a podcast that is it's called Low Carb MD Podcast. All right. But we don't take any commercial interest in that podcast, but I want you to be aware of who it is you're listening to. And then my family's financial disclosures. My wife has a, cookie company that she makes, baked goods. Now, I don't think this influences me, but It's a low carb, no sugar baked goods. And, obviously I want to see my wife succeed, and I don't believe that influences my dietary advice or my clinical judgment, but I figured we should disclose this. Okay. The objectives today, we're going to review obesity. We're going to review some comorbidities. We're going to talk about the guidelines. We're going to talk about epidemiology. Okay, we're going to review some neurobiochemistry. What modulates appetite? What modulates satiety? These are things we're going to discuss. We're going to discuss how to use low carbohydrate diets and intermittent fasting as a medical nutrition therapy. Okay, in 2019, it is an ADA recommended approach, a low carb diet. Okay, so welcome to 2019. Low carb diets are recommended for the management of glycemia in type 2 diabetes. All right, and we're going to discuss a little bit about remote monitoring of patients and how you can utilize that in the primary care setting, both for primary care and for weight loss. All right, so these are the things we're looking to do. Okay, what I want you to take away. All right, above all, if I can get you to walk out of these rooms today and realize that these etiologies, obesity, diabetes, fatty liver, depression, osteoarthritis, sleep apnea, they're not cemented in stone. These things are reversible. We reverse diabetes every day in our clinic. We take people off of insulin every day in our clinic. Okay? We get people off depression medications every day in our clinic. All right? It takes the right patient who's motivated, but this is what we do. These are not something that's cemented in their chart. Okay, and realize that these things are fluid. You do not have to accept that these things will be there permanently. Okay, so we're putting these diagnoses into remission every day. All right, another thing I want you to take away from this talk is that if a patient has tried to lose weight and failed, okay, you need to think outside of the box. It is not a moral, weakness. It's not a willpower deficiency. You need to suspect food addiction, binge eating, mental health issues, even childhood trauma. You need to consider what we are doing to the patients. Iatrogenic causes of obesity, the medications you put them on, maybe an SSRI, maybe a beta blocker. These cause weight gain, okay? And you need to consider that we've been giving patients terrible advice for the last 50 years. And I'd contend that repeated bad nutritional advice is probably the number one cause of iatrogenic obesity. All right, so you need to be mindful that nobody really wants to be obese. Okay, nobody wants to be obese. They want to lose weight. They want to feel good. If a patient has tried to lose weight and they've failed, okay, you cannot think that this is just creating a caloric deficit. People don't create caloric deficits. Yes, that way may work for some time, but creating a caloric deficit will increase hunger in the end, and you cannot maintain a caloric deficit in the face of hunger for long. You need to teach patients how to control appetite. Okay? Once you control appetite, the calorie deficit will come. Okay? Nobody needs to learn how to count math. Okay, nobody needs to learn how to use MyFitnessPal. Okay, this is not the reason for obesity. You need to discuss appetite with your patients. You need to discuss what is making them hungry. Why are they hungry? All right, so I'd want you to think about obesity as an appetite issue, not a math equation. All right, and again, I'm going to stress this. I've never met one obese patient who wanted to be obese. Okay? Nobody wants to be obese. All right? And you need to know that. Okay? You need to know that. So let's start with a case. Okay? The case we're going to start with is a 32-year-old male patient. He's got class 3 morbid obesity, prediabetes. He comes to you because he's tired all the time. His joints hurt. He has daytime somnolence. I bet you're thinking, maybe he's got undiagnosed sleep apnea. He's a medical resident. Maybe he's like one of you. Okay, he's working 80 hours a week. He has 2 children. His wife is pregnant with a 3rd. He's stressed out. And you know what? He's got a family history of morbid obesity, diabetes, hypertension, coronary disease. And he's seen his primary doc before. His primary doc said, go see a nutritionist. Okay, go see a nutritionist. All right? And the patient saw the nutritionist. And the nutritionist said, I want you to eat the size of your hand. He said, Or they said, you know, eat 6 or 7 small meals throughout the day. Okay. Or they said, eat everything in moderation. All right. His primary care doc has told him to eat more fruits and whole grains and to consider maybe eating more plant-based products and let go of the meat. Okay. He's tried these. They haven't worked. His primary care doctor has told him, you know, you really have to exercise. He's class 3 morbid obesity. He's got joint pain and he's tired all the time. And some doctor has told him that he needs to exercise. Okay. If that doesn't seem ridiculous to you, it should. And, you know, they've talked to him about bypass. All right. They've said that maybe you should consider gastric bypass. All right. And they've said it in a way that's judging and the patient feels stigmatized. Okay. Now the patient's presenting for your advice. What are you going to say? How are you going to approach this? What are you going to do differently? Let's remember this case throughout this presentation. Okay, I know I talked about this already, but obesity is not a moral failure. Nobody wants to be obese. Nobody wants to be stigmatized. Nobody wants it. Just like our, you know, patients with addiction, right? If you ask our addicted patients to heroin or cocaine or amphetamines, they will tell you, or benzodiazepines, they will tell you that it doesn't even feel good anymore. That they don't want it. Okay, they don't want it. I've yet to meet a patient who's wanted obesity. They're forced to accept it because your advice is terrible. All right? And it's not just your advice, it's all of our advice. It's terrible. We have basically watched obesity blossom. And we've told people to, you know, go low fat, drink skim milk, eat, you know, less and move more, and have 2,000 calories a day and count them real good. And they've tried. So either the advice sucks, excuse my language, or, you know, we need to, or we're bad clinical educators. Okay? They've been forced to accept their obesity because our advice is terrible. It's not a willpower deficiency. 1950 didn't come around and everybody just started not having willpower, right? This is not a willpower deficiency. It's not an inability to count calories. And I want you to understand something. Even us healthcare providers, when we count calories in the free living world, we're off by 10 to 20%. Okay? We're off by 10 to 20%. If your blood pressure cuff was off by 10 to 20%, you wouldn't use it. You wouldn't use it. Okay? So how does it make sense to count calories? Why would it make sense? The average layperson, okay, is off by 20 to 40%. Either because they're misunderstanding the size, okay, they're underestimating the size, or because they're just forgetting a meal they ate, or they're forgetting some foods they snacked on. So why would we use a metric that is inaccurate? It's inaccurate, even in the best of us. Okay, it's not an inability to count calories. There's calories everywhere. There's calories in McDonald's. There's calories on, everybody's got MyFitnessPal now. It's not an inability to count calories. It's not an inability to control oneself. Okay, I see plenty of obese people, okay, who go and run marathons. They lose weight and then they regain it. Okay, it's not an ability. They can control themselves, but you cannot control yourself in the face of hunger. Okay, you cannot continue to control yourself in the face of an appetite that's out of control. All right, it's not laziness. Okay, 40% of marathon runners here in New York City are overweight. All right, they want to exercise. That patient we talked about, he wants to go to the gym, but he's tired and his joints hurt. He's 400 pounds. And many of them are dealing with stress, mental issues, and emotional factors. And honestly, you may not even be able to relate to those. Okay? And now let's add to the problem. They don't want to see you. Patients with obesity don't want to see you. Because honestly, you don't know what to do. Maybe you tell them to take pills. Okay, maybe tell them to get surgery, all of which comes with some judgment, either that you didn't intend or that they feel. Okay, and pills don't work that great, and surgery, well, we'll talk about that. They don't want to see you because your exam tables in your room, okay, are weighted to 300 pounds. You can't even carry them. All right? Your chairs in your waiting rooms, they have armrests. They can't even fit in the seats comfortably. Your hallways are narrow. Okay? They don't want to see you because you don't know what it's like to be them. And there's more. I mean, the real reason they don't want to see you is you've never felt endless hunger. Okay? You haven't felt what it's like to want to eat less and you can't because you're always hungry. You've never had to ask for that seatbelt extender on the airplane. Okay? You've never had to miss a concert because you can't fit in the stadium seats, or not go to the movies, or not go to a carnival ride. You don't know what that feels like. You don't know what it feels like to be obese. You don't know what it feels like to try again and fail. Okay? And you probably can't get past your own preconceptions of obesity. All right? That it's a calorie deficit issue, or that it's an inability to count calories, or that it's a moral weakness, or a some sort of weakness. It's not. It's not. And to top it off, your advice sucks. Your advice has been, the guidelines have said, eat low fat, skim milk, more vegetables, more fruits, more grains. Okay? And it doesn't work. It's not working. If it worked, people would be doing it. People would be succeeding. You can't tell people to eat less in the face of uncontrolled hunger. All right? You can't do that. And the problem is massive right there in your home state and your neighbor, West Virginia. I think it's the obesity capital of the world. Okay? Look at this problem. This has absolutely blossomed, and it's blossomed on our watch. Okay? All the old attendings I see there with gray hairs and glasses, you were watching this happen. You guys watched this happen. I mean, I don't blame you. I don't blame you. I don't blame you. But this has blossomed on all of our watches. Okay? Nutritionists that are there, the dietitians that are there, you're responsible for this. Either because your advice isn't good or because the patient can't do the advice you're giving them. Either way, it's your fault. So let's us take responsibility. Let's us take responsibility. But the problem, I think, is a lot deeper than we even acknowledge. Okay? It's a lot deeper than we acknowledge. Right? Here we have on the left here a map of osteoarthritis. Osteoarthritis is supposed to be wear and tear of the joints. It's supposed to lag obesity by at least 5 to 15 years. But the prevalence and the map look exactly the same. Okay? Maybe I'd say that I'd put this theory out that maybe osteoarthritis is a metabolic disease. And look at that map of diabetes. It's not any different. Diabetes, osteoarthritis, obesity, exact same prevalence, exact same distribution. Okay? These maps look eerily similar. This is sleep duration on the left. Okay? Maybe this is a surrogate for chronic stress. We're a stressed out population. We're not sleeping. We're mentally ill on the right here. Look at these maps and look how close they look. Look at how, and let's talk about mental health for a second, because this is near and dear to us. The rate of burnout and suicide and amongst your peers. Look at the person next to you. Okay, out of the 3 people next to you, 1 of you is depressed. Out of the 10 people next to you, 1 of you is thinking about suicide. How did this happen? Was it always like this? They've blossomed. They've blossomed on our watch. Okay? And not only that, cancer has blossomed in just the same way. And heart disease has blossomed just in the same way and just in the same place. What is going on here? Are we thinking about this? Okay, are we thinking about this critically? There's these new epidemics. And I'm sure those doctors I talked about with the gray hairs and the glasses, okay, ask them about fatty liver disease. Did they see it 30 years ago? It was probably rare. And now we see it every day. I see it in 15-year-olds in my practice. Okay? Fatty liver is the leading cause of cirrhosis in this country and is related to metabolic disease and is related to obesity and diabetes. Okay? PCOS, same exact thing. I'm seeing it younger and younger. There's an epidemic of metabolic disease and it's blossoming on our watch. Are you thinking about what's causing it? Are you considering what explains this all? Okay, what explains this all? What is the underlying issue? Is there an underlying issue? Am I just looking too deeply into things that maybe aren't related? Can we find a unifying ideology for all of this? Okay, do we have a MyFitnessPal deficiency? Is that the cause of obesity? Let's just focus on that for a second. Is it because we don't have enough gyms and fitness centers, hypo gym and fitnessemia? Is it a gastric bypass deficiency? Okay, is our society lacking gastric bypass? Do we not have enough endogenous phentermine? You know, phentermine is the medication we use to cut appetite. Is that the problem? Okay, there's something equally absurd. Is it genetics? Did genetics change starting in 1950? Are we actively mutating over the last 15 years? Right? Let's think critically. Is it a willpower deficiency that started in 1950? It's not. And then, you know, I was at a conference very recently, you know, with all these bigwig researchers and, you know, at Obesity Week, one of the biggest conferences on obesity, and they're talking about all these associations. Well, you know, obesity is associated with artificial light, irrespective of sleep. It's associated with TV and advertisements. It's associated with lack of exercise and video games. You know, can video games explain this? It's associated with the amount of heat and air conditioning units in cars. And yet nobody's mentioning the crap food that we eat. Okay, the crap food that our dietitians say should be included in a diet. The crap food that, you know, we're told to eat in moderation. All right, nobody's mentioning this. They're talking about genetics and bypass and phentermine and topiramate. Talking about gyms and exercise. Eat less, move more. All right. So anyway, let's go back to our patient. So you have this patient, 32-year-old. Okay, and you're thinking about surgery in him. It's not a bad thought. Surgery is helpful. Okay, surgery can help people. You have improved outcomes with surgery. So let's just take a look at what happens with surgery. In the first year, it's very potent. Roux-en-Y gastric bypass, a 30% reduction in weight. Gastric sleeve, 25%. Okay, gastric banding, which is not used so much anymore, but still somewhat used, you get a 15% reduction in weight. Okay, very potent. They come with side effects. They come with issues, right? Nutrient absorption issues. But I think something's really important here that we may not see. We may look at this and say, wow, how potent that is. Our surgical colleagues are doing so much better than us, right? Why don't we step up our games, right? But this graph, it shows something else to me, okay? Are we all destined to regain weight? Weight regain after bypass is ubiquitous. It is considered an absolute going to happen at 2 years. Okay, after 2 years, if you notice here, there's steady weight regain. Why would we have weight regain after we've removed the stomach? We've forced people to eat the size of their palms. This is what we're forcing them to do, and yet there's weight regain. We're taking their ability to absorb nutrients away, and yet they're still gaining weight. What is going on? What is driving this? Are we all destined to just keep gaining weight? Was this how it was 100 years ago? And maybe you say, oh, we'll send that patient to a weight loss doctor, the big wig like Tro over here, or, you know, the weight loss clinic you have there, which I know is excellent. Okay, and we have drugs now. We have excellent drugs. A few of them are listed here. The most potent of which may be phentermine and topiramate, which is a potent appetite suppressant. Okay? It works well. You see a 10% weight loss here. And now look here, we have a bupropion and naltrexone. We're using a mu opioid antagonist, that blocks addiction in obesity. And it works. Are you considering addiction as the etiology of obesity? Have you considered that? Okay. And there's liraglutide. It's a great, or Saxenda, or, you know, there's a lot of GLP-1 drugs that work excellently. And they also help with glycemia, right? There's a lot of drugs we have now. Lorcaserin, which is a cousin of fenfluramine, a potent appetite suppressant. But does this explain what's going on? Or is it just a Band-Aid? Is it just a Band-Aid? And I want to focus on the most potent of the drugs we have, because what you saw with surgery, of course, happens with the medications as well. This is from the 2-year data that they used to get FDA approval of phentermine and topiramate. All right, if you notice here again, at 1 to 1.5 years, there's a very impressive weight loss. Okay, but what goes on right after 80 weeks? And you see it in their intention to treat arm. You saw that this number keeps going. I don't have that graph, but are we all destined to keep gaining that weight? You know, we're giving medications and drugs, right? Is weight gain is that cemented in stone? Are we all relegated to weight gain? Why? So let's start by admitting failure, because we don't know, right? We don't know. We don't know. We may have some good ideas, but we don't know. And as I said, our profession has basically overseen this explosion of obesity and metabolic disease and cancer and diabetes and mental health issues. We've just watched them. We've tried our best. Okay, we've tried our best, but they've blossomed on our watch. And we're too busy with Epic and pharma drug rep lunches and worrying about Tylenol and Colace pages. I'm sure some of you residents are probably getting that right now. So I think we failed our mission and we failed our oaths. I don't mean to be overly pessimistic, okay? And I don't mean to be overly critical, but we need to wake up. All right, and even the best of us, the most interesting and thought leaders in obesity and metabolic disease and diabetes, you know, they point to these graphs. They came up with this graph of all the different influences on obesity, and they don't know. They don't know. Look at how confusing this is. Okay, they don't know. Right? Is it the food, the environment, the biology, the genetics? Is it the social factors? They don't know what's driving it. All right, they're trying to figure it out. And then one week they say that eggs are great for you. And the next week they say eggs are bad for you. And then eggs are good for you again. And then they're bad for you again. Okay? So they don't know. They don't know. And they're relying on nutritional epidemiology to drive what to do for that patient who's sitting in front of you. Nutritional epidemiology says one thing, maybe limit eggs. Maybe that's what it says. Maybe it doesn't. Depends on the week. But then what does that patient want and need in front of you? All right? Those are two different needs. Two different needs. So the experts, they don't know. And they flip-flop every week. Why would you trust them? Why would you trust? I wouldn't. If you were a patient, why would you trust them? Right? I don't trust them. Okay, maybe they want you to be confused. Like here, I'm going to go cynical, and whether the schizophrenic obesity doc's going to tell you, maybe they want you to be confused. Okay, maybe they want you to be the paranoid schizophrenic here. Maybe they want to monetize your confusion. Here is a company, okay, owned or partially owned by one of the world's premier researchers in obesity, longevity, and fasting. His name is Walter Longo. Excellent researcher. Okay? But here he is monetizing his data with these supplements, his fasting mimicking diet. Okay? His fasting mimicking diet. And I support fasting. But do you need to, why are they selling it? Somebody tell Walter Longo the patients can fast for free. They can fast for free. So maybe really the industry benefits from everybody being confused. Okay? Maybe the industry benefits. All right. So you're like, I don't have time for this. Tro, just get to the point, right? I'm here on Grand Rounds. I got lunch to eat. Get to the point, right? There's a cute pharma rep and I got to go, right? The Saxenda rep is here. I just want to give my patients Saxenda. I only have 7 minutes because I take insurance. Okay. I have 7 minutes because that's what the insurance companies give me. Just tell me what to do. So you don't want to think critically. So you turn to the guidelines. Okay. It's reasonable. It's reasonable. You don't want to think critically. You turn to the guidelines. All right. What do the guidelines say? This is what will happen if you send them to a nutritionist or a dietitian. Okay. They will get something based off of this. Not exactly this. It'll be individualized care, but it'll be based off of this. And I'm sorry to my physician colleagues out there, my nutritionist colleagues and my dietitian colleagues. You may be excellent. And I'm just, being a little contentious. So it's not, don't be insulted. All right, but where does this come from? Who do you think agreed and happily endorsed these guidelines? Nestle did. Okay, and what do the guidelines basically say? More fruits, more grains, lower your fat, lean meat, and don't forget to eat less and move more. Okay, that's the advice. No wonder why your patients don't want to see you. No wonder why they don't want to see the dietitian, right? More fruits, more grains, lower fat, lean meat. That makes sense. They should lose weight. They should lose weight only if they ate more fruits. Well, let's make sense of this, okay? What happens to other animals when they eat our food? All right, this was an excellent study done about a year ago on raccoons. They looked at raccoons, in the Montreal area, and they compared the weights and essentially the A1C of raccoons that were in and around the city versus in the suburbs versus in the rural areas. And what do they find? They find that the city rats are basically diabetic and obese. The suburban raccoons, are less diabetic and less obese. And the rural rats basically have none of them. None of that. Okay? And I love the fact what they put here in this graph, access to garbage. And I love these veterinary researchers because they are calling our food garbage. And I think it's an appropriate designation. They call it garbage, yet we include it in our heart-healthy, whole-balanced, moderated diets. Raccoons eat our food, they get fat and diabetic. They rummage through your garbage, they get fat and diabetic. Why do we think we're different? Why do we think we're different? Do these raccoons have a willpower deficiency? Should they be exercising more? Are they watching too much TV, playing too many video games? Is there too much heat and AC in wherever they are? Right? Don't forget the pizza rat. I don't know if you guys know pizza rat. So the pizza rat in New York City, he carried the pizza all the way down the stairs. All right? They're eating our garbage food. And I'm so happy those scientists called it garbage. Okay, this problem extends beyond, maybe you're like, I'm not a raccoon, I'm not a rat. Well, in Melbourne Zoo and zoos across the world, essentially, there was a problem. The monkeys, okay, they were getting too many dental cavities. Okay, they were getting too much obese. They were getting obese, right? They were getting diabetes. And the head vet in the Melbourne Zoo says, we're going to limit fruits. Okay, we're going to limit fruits because these animals, these primates, are selectively eating the fruits and they're not eating anything else. And he says that the fruits are modified to be so sugary. Okay, we did too good of a job. We tried to solve the worldwide hunger issue, and we made fruits amazing. Okay, we made them amazing, and he says they're too sugary, these genetically modified fruits. And he removed them, and their health improved in the zoos, and the zoos across the United States. They've limited them. Well, maybe you're not a monkey, and maybe we're not all monkeys, right? Maybe. So here's the fruits. Are they all created equal? Should we all be eating all fruits all the time? Should we be eating 6 to 9 fruits because that's what the guidelines say? Well, are fruits fruits? Are they equal? Is this, watermelon, wild watermelon, the same as the Monsanto watermelon you're seeing? Okay? Is the wild banana the same as the bananas that we have in the supermarket? Are the carrots the same carrots that we're eating now? Are the wild berries the same berries that we see in Costco and BJ's and Sam's Club, Walmart? Are they the same? Is eating these foods on top of a caloric surplus beneficial? I don't know. I'm not sure. The population data says yes. But let's think critically. Okay, let's think critically. Other animals seem to do better when we limit some fruit. And are all fruits created equal? Is a banana and orange juice equal to a strawberry and a raspberry? No. One banana has 22 grams of sugar, about a half a can of soda. Okay? That's a pack of strawberries. Okay, big pack of strawberries has the same amount of sugar. Are they created equal? Not really. Not really. Are all vegetables created equal? Is broccoli, cauliflower, asparagus, spinach, kale, is that a potato? Okay? Right? Is that a potato? Is that a carrot? I'm not sure. Only if those raccoons and monkeys ate more fruits and grains, right? Wait a second, right? Wait a second. They're eating enough of that. They're restricting that, those vets. Okay, those raccoons they're getting obese off of what we're eating. So maybe not that. Maybe not that for the raccoons and the monkeys and the rats. Should they have joined the gym? Should they stop being weak? Were they slobs? Did they lack willpower? Did that pizza rat need to exercise more? Did that pizza rat need to count the calories? How absurd does this sound to you by now? How absolutely insane is it? Animals eat when they're hungry. Control appetite. It'll control the calories. Okay? It'll control the calories. Do these animals need to create a caloric deficit? Do they need to count those calories? Do they need a nutritionist? Do they need a bariatric surgeon to cut out their stomachs? The raccoons that are having a diabetes and obesity epidemic in the cities, do those raccoons need bariatric surgery or medications? Do they need close follow-up? Are we considering the big picture here? What about appetite control? What about the food composition? What is it that they're eating that's making them eat to the point of self-detriment? Okay, what is it they're eating that they're eating to the point that those monkeys are eating till they have cavities? That they're neglecting other foods because of those fruits? What is driving that appetite? Can we figure that out? Can we figure out what's making these foods so accessible that we have them in such large quantities and so easily? Have we considered these things? So let's eliminate all these things that sound completely absurd and just focus on the food for a second. Maybe it is the food. Okay, what would drive an animal to eat to the point of being ill? Am I talking about the raccoons or am I talking about the patients? Let's just say mammals for now. Okay? What would drive an animal to eat to the point of ill health? Well, we know sugar is addictive. We can get mice to eat sugar over cocaine. We can get them to pick it over cocaine. We have functional MRI studies with sugary drinks in lay people. It activates the reward centers like nothing else, like heroin does. But is there more to it than just sugar? Maybe there is. An excellent study very recently in cell metabolism showed that adding fat to sugar or processed carbohydrates potentiates that reward. Okay, let's think about this clinically. Okay, if you take what is the food that people crave the most? Chocolate or ice cream? What is it? It's fat mixed with sugar or a carb, right? People, okay, this is a great study that used functional MRIs. They're willing to pay more for fat and carbs, okay, more so than fat alone or carbs alone. All right, so think about what this means. It means it's not just sugar. There's more to it. Fat can play a role. All right, it's not just sugar that's addictive. Fat will potentiate sugar and processed carbs food reward. Okay, let's think about what this means. So does this theory hold true that fat and sugar is more addictive? Well, let's take a look at this group that took the YFAST, which is the Yale Food Addiction Scale, which is an absolute must scale for you to do in every morbidly obese patient. Okay? They took that food addiction scale and they presented it to lay people, and they sought to categorize the most addictive foods. Let's see what they are. Chocolate. What's chocolate? 50% fat, 50% sugar. What's ice cream? 50% fat, 50% sugar. What are French fries? 50% processed carbs, fried in an oil. Pretty much the same. Pizzas, 45% carbohydrate, 45% fat. You get a little bit of sugar from the sauce as well. Cookie, same split. Butter, flour, sugar. Cake, same split. Buttered popcorn, same split. Cheeseburger. Processed carb and flour in the bread. Okay, sugar in the ketchup. And you have cheese, the added fat. All right? And then you have things here that are independent. You know, sugar is obviously independently addictive. You have gummy candies here, soda, and breakfast cereal that are predominantly, you know, that whole grain breakfast cereal that we're told to eat more of. Very addictive. Plain bread, very addictive. But that theory mostly holds true. Sugar and processed carb on its own is addictive. Add a fat to it, oh man, you got food reward now. Think of it like this. Everybody loves bread. You add butter to that bread, they're going to eat a lot more. They're going to eat a lot more. Take a sugar, a processed carb, add fat, you have incredible drive to eat. Your brain is very happy. Okay? Well, let's bring it back to our patient, that 32-year-old obese patient, stressed out, working 80, the medical resident, just like one of you guys, working 80 hours a week. What should we tell him? Should we tell him, maybe you should do what the guidelines say? Okay, if you don't think that's preposterous by now, I hope you're at least considering that it could be preposterous. He's tried that. Maybe exercise, maybe eat better, maybe cut out the fat, right? That's what the guidelines say. Maybe what we just learned, should we tell him to cut sugar and fat? I don't know if that's a good idea. We'll talk about it. What does the patient say? He says, I tried Weight Watchers. I tried calorie counting. It doesn't work. Or it works until life happens. And then I can't do it. I can't do it. He's tried and he's failed. I've tried low-fat diets. It doesn't work. Okay, everybody knows about low-fat diets. Oprah did a low-fat diet. Everybody knows about it. I'd love to exercise more, like you said, Doc, but my knees hurt. I also have no time, and I'm tired all the time. I have undiagnosed sleep apnea that you didn't consider. I've seen the nutritionist. Didn't help me. Didn't help me. What should I do? What is your advice and why? Okay, are you thinking about this? All right, so let's just think about what we're going to tell him. Let's treat a dietary intervention like we would if it was a drug. What dietary intervention would you recommend? Low fat, low carb, plant-based, paleo. What would you recommend and why? Okay, why? Let's treat it like a drug. Let's look at the data and see what the head-to-head trial data shows. Let's think about the mechanisms. Why and how does this diet work? Okay? Remember that caloric deficit is a result. It's a result of thinking about dieting and trying to executively control eating less. That will run out soon. The ability to do that will under stress, will falter. But it is a mechanism. I'd like you to consider another mechanism, appetite control, hunger control, and that will lead to a caloric deficit. And you don't even need to think about calories. Just address hunger. Well, let's look at what the data shows. Low fat, low carb, what are we going to do? Okay, well, here's a meta-analysis from Mansour. This was from the British Journal of Nutrition. And what did it show? There's a slight advantage to low carb, very slight advantage, not much, 5 pounds. Okay, but for my patient, you know, he's tried low fat. It's a no-brainer. He's failed the other treatment. He's told you, Doc, this antibiotic you gave me for my infection doesn't work. I'm still infected. I still got a fever. Well, try harder. Try that antibiotic harder. No, it's ridiculous. Consider another modality. Consider another approach. So he's tried low fat. Low carb does better in the literature. Consider low carbohydrate. Okay, consider it. So it's not a huge amount. We're talking about 5 pounds, but it's something. Something. Well, they've done head-to-head studies. We don't need a meta-analysis. Gardner did a study in 2007, 10 years ago, 12 years ago. He compared Atkins, Ornish, Zone, Learn. Who lost the most weight? Atkins did. Atkins knew what he was doing. He knew what he was doing. We have the data. It's here. Some of you may say, oh, wait 1 second. Gardner did another study more recently. Okay? He did a study more recently. It was published in JAMA about a year ago. Okay? What did it show? It showed that low fat and low carb equaled out at 12 months. Okay? I mean, low carb did better here, statistically significantly better at 3 months and at 6 months, but that signal faded. Maybe you're saying they're the same. All diets are the same, right? Are they all the same? Are they all just a caloric deficit? Let's think about that. Well, if you look at diet fits closely, Gardner, who's a a plant-based advocate, what did he do in this study to equalize the arms? Well, Gardner went and told his patients in the low-fat arm and the low-carb arm to cut out all sugar and to cut out all flour, right? Cut out all flour. Cut out most of your grains. Cut out all that sugar. Okay, this is what he told both arms. And if you look at the difference between sugar in these arms, the added sugar difference at the end of 12 months was 10 grams. That's 2 teaspoons of sugar difference between the low-fat arm and the low-carb arm. He equalized the groups to get this result at 12 months. And still low-carb really did better. Did better at 3 months and 6 months, and did better, just not statistically significant at 12 months. So Gardner did a great job. Great study that he did here to equalize the groups. Okay, great study. All right, so what's the mechanism? How does it work? How do low carbs, how are they slightly better? All right. Some proponents say it's a spontaneous decrease in intake in ketogenic and low carb diets that range from the order of 600 to 1100 calories per day. Patients will just stop eating. Why? Is it patients report that they have decreased hunger and increased satiety? Other proponents say there's a metabolic advantage. Is that true? Critics say that, hey, the effect is just restricting the food group. All you did was stop them from eating carbs, so they ate less calories. Okay? The critics say there's no hormonal advantage. And the critics say, like Brad Schoenfeld, he gave a talk a couple years ago, he said, maybe low carb does better because they're just bored with their diets and they have less to eat and they're eating less. Okay? He said they're bored, that you're restricted. Okay? And other critics will say that there's no hormonal advantage. Kevin Hall says he believes there's no hormonal or metabolic advantage. These guys are smart. Let's consider what they're saying. I don't know. Does this diet look boring to you? What does that look like to you guys? You bet you're all hungry. I don't know if you're eating, but don't mean to spur your appetite. I know we're talking about appetite, but does this look boring to you? Not really a boring diet, in my opinion. All right. Some of those critics say it's only coming from protein. All right. You go on a low carb diet and the efficacy is coming from protein. And here's a study that shows what protein does to satiety, what it does to appetite. And they put these two groups of patients into basically a caloric deficit. They gave them like half the food they normally eat. In this study, it was 750 calories. It was not quite half, but okay. And the one group got a high protein diet. The other group got a normal protein diet. And what happened? The high protein group were less hungry, had less desire to eat, and they were more full. And they preserved more lean body mass. So maybe the effect is from protein. Okay, maybe it's just the protein in these low-carb diets. Maybe it's that protein leads to more thermogenesis, okay? So protein, when your body burns it, it creates heat, and it doesn't burn it as efficiently. So maybe you're getting this advantage just by having more protein in your diet, because really 4 calories of protein is actually 3 calories, because your body spends about 1/4 of that energy making heat from that protein. The meat sweats, right? So this is a real phenomenon, proven thermogenesis from basically, it's thermogenesis that's happens from digesting protein. Okay, so if you look at Atkins or Stillman or a ketogenic diet, sometimes they have a higher protein amount. All right, maybe that's the mechanism, the satiety and this thermogenesis. All right, but is that it? Is it just the protein? Critics say yes, that's just it. That explains it. What do you tell your patient? So it's just the protein. That's what's going to make you more full, and it's like exposing an inefficiency. It's like a hack. Is that it? Is it all about protein? Well, maybe not. Maybe not. So this is an interesting study, okay, done in 2008, where they took patients and they put them on basically a ketogenic diet. And they found that as long as they fed patients on a low-calorie ketogenic diet, that they're basically a ketogenic diet or a low-carb diet, they're interchangeable, okay? They maintain a hormone called CCK. CCK is released when we eat protein and when we eat fats, okay? And even though they lost weight, okay, on this diet, this weight loss diet, All right, they maintained their CCK. And now if I take CCK and I inject it in you right now, your pylorus is going to contract, your gallbladder is going to release a bunch of juice, and you're going to feel full. If I put you in front of a Chinese buffet, you're going to eat 30% less if I inject you with CCK. Well, ketogenic diet preserves that. And then when you go off the ketogenic diet, like they did in the 9th week here, those levels drop. Okay? Statistically significant drop. So ketogenic and low-carb diets preserve CCK. Preserve CCK. So maybe there's a unique hormonal effect on satiety. That's not the only hormone. Neuropeptide YY. This was an excellent study done for a year. They put people on low-fat versus low-carbohydrate diets, and they fed them for a year. And they saw what happened to the satiety hormone, neuropeptide YY. It's a hormone. Again, if I give it to you in front of a Chinese food buffet and I inject it in you, you'll eat about 20% less. If you eat low carb, it's preserved despite weight loss. Okay, if you eat low fat, it's gone. Right? You're not eating fat. You're not eating protein, right? And so this hormone decreases. You're losing that satiety hormone, right? It has an effect, a unique hormonal effect from low carb diets. And also ghrelin, the hunger hormone. This is a great study. Showed that this was a weight loss diet they put patients on, and they showed that as long as they kept ketogenic, that the ghrelin was suppressed. Usually with weight loss, you get ghrelin that goes up and counteracts the weight loss to get you to go back to your set point, okay? But a low-carb diet and a ketogenic diet, when maintained in ketosis, preserves that ghrelin, keeps that ghrelin low and suppressed. And when you go off the ketogenic diet, that ghrelin increases in week 10, okay? So there's some unique hormonal effects seen in low-carb and ketogenic diets. All right? It's not all calories. Okay? The protein, the hormones. Well, what about insulin? This is like a hot topic. Okay? Several studies have shown that low-carb and ketogenic diets reliably lower your fasting insulin, improve your insulin resistance, improve glycemia. In fact, now it's in 2019, it's recommended as an ADA medical nutrition therapy. I would ask your dietitians, do you have a inpatient low-carb diet yet? It's part of the guidelines from the ADA. But is insulin something we should pay attention to? Some say yes, some say no. All right, what about that insulin thing? Well, does insulin cause weight gain? When we look at the Accord study, so I'm sure a lot of you know the Accord study was a study that looked at aggressive diabetes treatment versus a standard diabetes treatment, and what were the outcomes? And when we look at the weight outcomes, what happens? Weight goes up on the aggressive arm, in the intensive arm. More insulin, more sulfonylureas, more weight gain. Pretty clear signal here. Same thing in UKPDS. More insulin, more sulfonylureas, more weight gain. Okay? Same thing in the ADOPT. More sulfonylurea, more insulin mimics, right? The exception is the GLP-1 agonists, which only increase the first phase response. So some may say, wait a second, GLP-1s are insulin mimics, but they lower weight, and that's true, but they act on that first phase response, right? They act on the first phase response. So it's a little bit different, but for the most part, it looks like when we look at the clinical data, insulin causes weight gain, all right? Well, let's just think about this clinically, okay? Because we know this. What happens to your patients if you give them too much insulin, right? What happens when they say, my blood sugar's low? Do they say, oh, wait, let me go eat some broccoli and asparagus and a little bit of grilled chicken? No, right? You know what happens. They say, give me the orange juice, give me the chocolate. I need to eat right now, okay? Is it their fault that they're hungry when their blood sugar fluctuates? Okay, is it their fault? Is it weakness when their glucose drops that they're spurred to eat? Okay, they will annihilate anything between them and a candy bar, right? We know this clinically. What does insulin do? Increases hunger, right? Well, some say no, some say not really, and maybe they have a point. Okay, if you actually sniff insulin, it actually increases your post-meal satiety. Here's a study of intranasal insulin. So on the brain, as a satiety hormone, insulin says you're full. But what happens to your body when you release a ton of insulin or you administer insulin and the blood sugar drops even slightly? Brain thinks hunger. Okay, and it's not the frontal lobe that's saying, maybe let me eat some eggs, chicken, Greek yogurt, saying, give me the food reward. Give me the carbs plus fat. Give me the chocolate, the ice cream, or the sugar. Give me the orange juice. Okay, what does insulin do? Let's think about it. So actually a group put this theory to test. Okay, they said, we're going to do a clamp study. We're going to hook people up to functional MRIs. We're going to give them an insulin infusion, and we're going to keep their blood sugar stable, and then we're going to drop them just a little bit. And we're going to see how much they want hyperpalatable foods and see what happens. Okay? We know what happens. What do you think happened? So they dropped the blood sugar of these patients in this functional MRI just by like 20 points, from the 100 to 110 range to like the 70 to 90 range. Not a lot. They gave them enough insulin, they kept their blood sugar stable, and they saw what happened to their appetite. Then they compared it, what happens when it just drops a little bit. What do you think happened? The addiction centers of the brain are lighting up. Okay? Not in everybody, but more so in the obese people. More so in the obese people. Meaning that if you have insulin resistance, okay, and you have these glycemic shifts, all right, and you have these, blood sugar shifts, your brain is going to get hungry, okay? And if you're obese, it's going to get more hungry, all right? These glycemic shifts are increasing desire for hyperpalatable food. We show it on fMRI. We know it clinically when people overdose on insulin or they take too much or they take too much sulfonylureas. If you're still using a sulfonylurea, you should just stop. Okay, unless you're dealing with a poor population, right? You really should just stop. There's no reason at this point to use a sulfonylurea in diabetes. It just causes weight gain. I'd argue you shouldn't really be using insulin in type 2 either. Okay, because diet is powerful, and we take people off insulin every day. Anyway, the glycemic shifts increase this reward, okay, and more so in the obese. More so in the obese. And this is an interesting study. Keep talking about insulin here. This was a study in Japanese workers. They looked at a diagnosis of diabetes, and they looked back. What happens 10 years before, all right? And what did they see? Weight gain slowly goes up before a diagnosis of diabetes. Their fasting insulin slowly goes up. Look at that. And yet we never check fasting insulin. And look at their blood glucose and their A1C. It kind of modestly goes up until it blossoms. We are watching that blossom. We are watching that happen. And it's too late. We want to capture this before it's a problem. Okay? We want to capture it before it's a problem. So rising insulin and weight gain precede diabetes. Precede diabetes. Maybe they're hyperinsulinemic. Maybe they're having glycemic shifts and that's driving them to eat. Maybe they're eating our crap foods filled with crap oil and sugar and processed carbs. And that's driving their hunger even more. And they're driving their insulin up even more and causing their glycemic shifts even more. Maybe it's endless hunger. Does that explain it? Well, maybe the mechanism is something else completely. Okay, David Ludwig did an excellent study. This was just released a year ago, not within the year. He fed people for a year, differing diets to see what if low-carb dieting increases your metabolism. So he fed them for a year in a low-carb, moderate-carb, and high-carb diet. And he measured their metabolism using doubly labeled water. And he kept their weight stable. He fed people for a year, a massive study, millions of dollars. And he found that a low-carb diet actually increases metabolism by up to about 400 calories, right, over time. All right, it's potent. So maybe low-carb diets also work by increasing your metabolism. Maybe there is a metabolic advantage. And Kevin Hall did a study, right? If you're going on a low-carb diet, it's really hard to eat processed food, right? All that granola and cereal and chips, right? Those are gone. And Kevin Hall did a recent study where he kept all the macronutrients equal. in 2 groups. And he basically fed one group processed food, and he fed another group unprocessed food. Okay? And what did he find? That on the processed diet, you will eat up to 600 calories more. And you will gain weight 600 calories a day more. So here we have 2 other potential mechanisms. Maybe the processed food reduction in low-carb diets is why it works. Maybe it increases metabolism by 400 points over a year. So are we considering these as potential mechanisms? So how do we unify this all? I kind of hinted at it. I think that way we can unify this is these unhealthy fats and these combined with these sugars in the processed food we're eating. It leads to insulin resistance. And that insulin resistance leads to glycemic shifts when we eat these foods again. And those glycemic shifts increase our desire for food. Why is it that after Thanksgiving dinner, everybody's full, and then the pie comes out and everybody's hungry again? Why is it that 2 hours after a Chinese food buffet, everybody's hungry again? After 5 slices of pizza, okay, 3 hours pass. Why are you hungry? Why are you hungry? Why are you hungry after that, cheeseburger meal at McDonald's with French fries and a milkshake? Why are you hungry again 3 hours later? They're not keeping you full. They're not keeping you full. And so when you eat those foods in the setting of insulin resistance, it leads to this cycle of endless hunger. And what does endless hunger cause? We see it in the raccoons. Diabetes. That's what they get. Why are we any different? Why do we consider TV? Why do we consider air conditioning? Why are we considering lack of exercise, which may be a factor? Okay? Why are we not considering the food? The crap food that we're told to eat in moderation, as long as it's low fat. The granola bars and the cereal that are voted on the top 10 most addictive foods. Okay? Why? All right, so you're like, okay, you convinced me. Crazy bald guy on the screen. Tell me what to do. Okay? Well, here you have your 32-year-old patient. What are you going to do? Well, you're going to talk to him about low-carb dieting. Keep your processed carbs and sugar as low as possible. Aim for 30 grams of total carbs a day. Focus on meat, fish, eggs, Greek yogurt, seafood. Okay? Non-starchy vegetables. Eat them all you like. Cauliflower, broccoli, asparagus, Brussels sprouts, spinach, green leafy vegetables. Low-carb fruit. Go ahead. Peppers have more vitamin C than an orange. Okay? Calorie for calorie. All right? Zucchini, a low-carb fruit, has more. Pepper is also a low-carb fruit. Zucchini has more potassium than a banana. Calorie for calorie. So if you're worried about potassium and vitamin C and blah, 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 okay, you have an option, a low-sugar option. All right? You have a lot of low-carb fruit, olives, avocados, healthy, berries, strawberries. Okay, strawberries, raspberries, and blackberries have 1 gram of carbohydrate each. You can have 30 of them, and then eat a bunch of chicken, meat, fish, plain yogurt, seafood. For people who are bingers on sweet and savory items, tell them you can make a low-carb cookie. Just Google low-carb cookie. My wife mixes. All right, here I am, biasly promoting my wife. If you're watching this, Rosette, I love you, and I hope that I hope you do well. Okay, if you have a chocolate or ice cream binger, right, or ice cream binger, they can do no-carb protein shakes. These are not ideals, but you could swap them out to get them low-carb, to get all those satiety benefits that we talked about, to get maybe this increase in metabolism, okay? If they're addicted to chips or they really like chips, get them to get protein chips. Nuts and cheese are great snack food. You could put them in the workplace. They're great for induction. It gets people off the sugar and carb train. And then the focus of the diet eventually should be meat, fish, chicken, Greek yogurt, non-starchy veg, low-carb fruit. That's a core of a low-carb diet. And these other things, they're not ideal for induction. Okay? They're not ideal. They're only ideal for induction to get people through the beginning, which is a terrible time if you don't advise your patients on what to expect. So what should they expect when they start this low-carb diet? Well, you tell them you're going to feel miserable. Okay? Why are you going to feel miserable? Well, you're used to glucose, and now you're not taking any more of it. Your body has to burn fat, and it doesn't know how. It takes 1 week for your fat oxidation to peak out. It takes weeks, 3 to 6 weeks and maybe even longer for your ketones to peak out. Okay, meaning the machinery and the silos, they're not going to be ramped up for weeks. So you advise your patients, you're going to feel a little bit different for the first couple of weeks. And also advise them you're going to feel lightheaded. Why is that? Because this red line is what insulin would look like. It's going to drop down. And when insulin drops down, there's a natriuresis, okay, where you lose salt and you lose water. Okay, so they're going to dehydrate. I know I'm running over. I'm going to try to finish up. I'm going to make this real quick. So make sure to tell them to drink water, salt their food to taste. And don't feel like you're going against the guidelines, because all that processed food that they remove has a ton of salt. So don't worry about them salting their food if they stick to the diet and don't have the processed food. Okay? They have to drink water till their pee is clear. That's the advice. 30 grams of carbs. Drink till your pee is clear. Salt your food to taste. All right? Remind them that it's a tough first couple weeks. It's tough. And don't tell them to restrict early on. Tell them to eat as much as they want, because when these ketones rise up later on, that's when their appetite will be suppressed. Right? We went over those hormones and what ketosis does. Okay? So if they want to restrict, tell them to save it for 4 to 6 weeks in after they're adapted to the diet. Don't restrict early on. It'll make it worse. All right. Well, this natriuresis effect, I wanted to show it to you in some of our remote data here. And I'm finishing up here, I promise. This is somebody I just, I've seen it over the past month. We stopped his blood pressure medication the first week. Okay, look how potent this natriuresis is. He's off of 2 blood pressure medications in the first week, and his blood pressure's down from the 150s over 100s within a month, off of 2 medications, without any weight loss, into the normal range. So the natriuresis from that high insulin, okay, dropping down is very potent. All right, make sure they hydrate, make sure they add salt, make sure you monitor their blood pressure. You see how potent it is. Don't blame salt for what the sugar did. Okay? Sugar is driving this. I see this every day. Insulin drops. I tell my patients to eat fat and eat sugar, and to eat fat and eat salt, and their blood pressure drops. Here's what a CGM looks like, more remote data. This is somebody who just started with me. And you see that top CGM data. This is their blood sugar throughout the day. You see how it's going into the 200s. All right, and coming back down. What do you think they feel like with those glycemic shifts? Hunger. Just ask them. They'll tell you. What happens if you eat banana and oatmeal? What happens 2 hours later? I'm hungry again. What happens if you eat 3 eggs? I feel fine. I feel great. I could go for 6 hours without eating. Right? And so that's what it looks like. Couple days in, their glycemia improves within days. So take them off the sulfonylureas. We take people off insulin on day 1. Just like our surgical colleagues. Day 1, we take our patients off insulin. Okay? Look at what's happening here. Immediate effect. All right? Discuss the risks and the benefits. Benefits. Best diet in the real-world setting in the literature. Benefit. ADA recommended approach for glycemia. Risks. There's no outcomes data. What happens to me after 5 years, doc? Am I going to get a heart attack? I don't think so, but we don't know. There's case reports of ketoacidosis, especially with SGLT2 inhibitors. Be careful. Okay? There's case reports of familial pancreatitis and pancreatitis and familial hypertriglyceridemia. Because when you start the diet and you add all this fat and protein, those triglycerides initially go up, but then they go down. They go down. A potent way to decrease triglyceride is remove carbohydrates and sugar. Okay? But it takes time. Okay? And then there's theoretical risks. What happens if the LDL goes up? Am I going to die? Okay, am I going to get a heart attack, doc? We don't know. We don't know. In the literature, pretty consistent signal. Okay, about 2/3 either improve or maintain their LDL. About 1/3 go up. But triglycerides, HDL, and glycemia reliably improve. Mixed signal. There's a theoretical risk of stones. Okay, but that'll dissipate if you tell your patients to drink water until their pee is clear. Okay, observational studies about saturated fat and meat intake. Well, there's observational studies that show there's no issues with meat intake. It's called the PURE trial. So I don't know what to make sense. The signals are not clear. Okay, but tell them this is what it shows. The AHA recommends less meat. Sorry, cardiologist, if you're in the room, we're going to tell our patients to eat more meat. And just remember to try other approaches. The goal is to decrease hunger. So maybe you've pushed down the low-carb arm and you can't push anymore. Okay, fine. Push down the intermittent fasting arm. Tell them to restrict hours, not calories. Okay, these are things you can consider. You can consider going paleo with intermittent fasting. You could even consider a ketogenic diet, a plant-based ketogenic diet or carnivore diet. Okay, in any case, let's wrap it up. What do we tell this patient? Your patient will thank you when you know these different modalities. What do we tell our patient, the 32-year-old? Well, the patient was me. That was me. That was me before low carb and intermittent fasting. And that's me now. That's me now. Sorry I went over. Can I answer any questions? I know I went over. I'm sorry, Stephen. Can you guys hear me?
Yeah. To answer questions.
Okay. Sorry, I'm going to stop the share. You guys can see me now?
Yes, we have a giant U.
Yeah. Sorry. Sorry about the 5 o'clock shadow. Yeah. Can I, do we have time for questions, or is it like, somebody begging to go into the room?
I have a quick question. So a lot of the alternatives that you were, for the low carb diet that you were mentioning, they all seem expensive in my experience. So what do you do with patients who are in a lower socioeconomic status and might have trouble obtaining those things?
Yeah, so we've looked into this. So we're in the New York City area. The SNAP benefit in the New York City area is $10. Okay, it's actually $15. We've been able to create a great weight loss ketogenic diet for $10 a day. Okay, it would be, canned salmon, canned tuna, frozen berries, frozen vegetables, family packs of ground beef. You can get pork belly for cheap. There's a lot of different cuts of meat. Chicken breast, chicken thighs are cheap. Okay, so there's a lot of ways you could do it for inexpensively. Plant-based vegan is very difficult. A plant-based ketogenic approach is a little more expensive because there's a lot of coconut flour and almond flour, which are kind of pricey. But for a typical low-carb ketogenic diet, look, you could go to McDonald's, you get 5 hamburger patties for $1 each. You get 1.5 pounds of meat for like $6. Okay, it's doable. It's doable. So if you're in a jam, I'm not recommending. I have no affiliation with McDonald's or Wendy's or wherever, but you can go to any one of these places and get $1 a patty of chicken or beef and maintain a low-carb diet fairly easily. But if you're looking at it from an economic perspective, you want to go for the canned salmon is great, canned tuna, the family packs of meat. The only issue you'll run into is if you're talking about like SRO housing, like single room. I don't know if you guys have that there, but in the New York City area, we have kind of like, it's like a dorm style public housing where cooking, like they don't have access to kitchens. And then it becomes really a little bit more difficult and challenging. Does that answer? Ultimately, you're actually going to decrease intake, so you'll probably save money, because once the appetite suppression comes in and you'll start intermittent fasting when those ketones are high and satiety hormones are high, you're going to eat less. So does that answer your question?
Yeah.
Okay. Any other questions? I can't see anybody, so.
Hi, my name is Becky. I work with Stephen, not in the clinic, but otherwise. You mentioned at the beginning that we should take into account a lot of things about our patient, including sort of psychosocial factors that have played into their development of obesity. And then we focused a lot on the physiology of eating and nutrition. When you're sort of assessing your patients, how do you consider how some of those previous, mental health or restrictive eating habits, disordered eatings kind of play into your patient's current nutritional status? And how do you kind of take that into account when you're recommending this diet? Because it could, potentially exacerbate some of those issues.
So there's never been any credible evidence that restricting a restrictive diet, quote unquote, will cause an eating disorder. Okay, there's no real credible evidence to support that claim. In my my review of the literature, I've looked into this before. There's proponents of, flexible dieting and the kind of standard approach that dietitians and nutritionists use. And one of the points they'll say is, well, we want to do everything in moderation. We don't want to cause an eating disorder. But I see no evidence that that's actually the case. And when you're talking about, so if you're talking about like anorexia, that's a completely different beast. I think if you have an anorexic patient, that you have to treat that very delicately. If a patient with a history of anorexia, I think bulimia fits on that binge eating, food addiction kind of spectrum. And I think you can more easily manage that with low carb approach or diets that restrict the food group. Okay, so I have less hesitation. I've had we have a case series coming out pretty soon on ketogenic diets and intermittent fasting for binge eating. We have patients who were basically eating pizza until they were full, for years, 10 years, stop and not have that problem. And we have patients who are eating, chocolate, running out in the middle of the night to buy chocolate, just, resolving essentially. So there's a case series pending on food addiction and binge eating that hopefully we'll have out soon. So I'd say that if you're on that binge eating kind of food addiction, and even bulimia to some extent, I think that good, sound nutritional counseling could help. Now, if you're talking about childhood trauma and depression, and let's say there was sexual abuse and somebody was eating to make themselves, not beautiful in a self-protective mechanism, or deep depression, I think these are a different entity, and different issues need to be considered. You cannot, erase, sexual trauma with a ketogenic diet or intermittent fasting. That's just with any diet. Okay. So I think you have to realize the limitations of the diets you prescribe.
Troy, we have a question from the VA. They're chatting in. So how do you fit the low carb diet in with the developing food crisis, including the science-based BLUF diet? I'm not familiar, but maybe you are.
So I think that the question here is, how do you reconcile environmental and possibly even animal rights issues with regards to dieting? And I'm going to defer here, because I'm going to say I'm not an environmental expert, and I'm not a animal rights connoisseur. I could say that I've been out to regenerative farms that don't do monocropping, when they basically make these massive soy fields with just one crop, they kill the land and they kill all the field mice and stuff like that, and corn fields as well, these monocropping. So I think the future is really, and the same goes for like the other end of the spectrum, these massive slaughterhouses that are just insanely cruel to animals. I don't think we can support processes like these in our agriculture that don't respect the earth and don't treat the earth well. And I've been out to regenerative farms that kind of, they graze on one quarter of the land, they farm on one quarter of the land, and they leave one quarter of the land to basically rest, and they, swap these. So I think that there's ways to eat in a way that supports the environment and supports moral, kind of ethical ways of eating. If you buying free range eggs and getting to know your butcher and asking where the meat comes from is a big first step. I don't know if that answers the question, but hopefully that does. Any other questions?
Yeah, one more.
So back to the question about people who have like restrictive eating issues or binge eating. At what point do you say that, like, because you keep saying that it's a hunger control issue, but it's also, you look like you're going to say something.
No, I just wanted binge eating. I just clarify the etiology we're talking about.
Yeah, so let's specifically like binge eating, bulimia, that focus. I just want to know what your opinion is on that as far as it actually being hunger. Because a lot of people who binge aren't hungry. They're just eating. and they'll eat and eat and eat until they throw up. And then after they throw up, they'll eat again. So where is that? It's not hunger anymore. So at that point,
yeah,
I think if you have a patient that relapses like that, what's your advice with going back to low carb?
I think that cases like that are definitely more on the psychiatric spectrum, you have to treat more on the psychiatric spectrum and work closely with counseling and maybe cognitive behavioral therapy and really close follow-up. Okay, close follow-up. When there's a strong psychiatric component, okay, and it's very clear that the signal is not appetite, and don't expect to get results when you're treating appetite. I think it's really important to do, as you're saying, is figure out the etiology here. If it's not hunger driving it, right, or if it's not desire for food reward, then why would you go down that pathway? So I agree with your idea, but I find I can't tell you how many times I've had patients with bulimia and lifelong obesity cry in my office when I tell them they can eat until they're full and they don't have to worry about it, and all they have to do is keep their carbohydrates to less than 30. They'll cry and say they've never been told to eat until they're full. So I think you have to address the patient in front of you. If there's a strong psychiatric component, whether it's bulimia or anorexia, you have to treat that differently, very differently than just kind of the run-of-the-mill obesity.
And just one other question about, just for clarification, when you're recommending these low carb, low sugar diets, at no point are you restricting calories. You're just looking at switching the macronutrients in which you're primarily consuming.
Well, so let's be clear about that. In the first 2 months, there's absolutely no restriction. Okay, and that's due in part to the timing of some of these satiety hormones and ketone production and how long it takes your body to be able to adapt to fat usage for fuel, right? So when you look at like the athletic data for ketogenic diets, there's a performance decrease basically less than 4 weeks, and then performance levels out around 4 to 6 weeks, and then improves 6 to 12 weeks. So it takes time for the body to get used to using fats as an energy source and ketones as an energy source. So I don't think restricting in the first 2 months is appropriate. Okay, even for weight loss. In fact, I'll tell patients do not restrict in the first month when they're already hypocaloric, cutting out a whole food group. They don't know how to do this diet, and they're going to face intense cravings, right? So I tell them to, eat until they're absolutely full. And then what we do we create a caloric deficit when their satiety hormones are high, right? So when they come to me at week 3 to week 6 and say, I'm not hungry. I skip breakfast. I skip lunch. And then we'll push down the intermittent fasting modality. And instead of having them focus on, because it's really inaccurate to go with calorie counting, we just go with hour counting. And it's a fairly good surrogate. We tell them to restrict the amount of hours they eat. And we start at like an 8-hour eating window per day. And we told them to titrate that down based on their weight loss. And it really works well with low carb dieting, intermittent fasting. On its own, it can work well because intermittent fasting will improve food quality. If you're going to make it 16 hours without eating, you have to have high protein, high healthy fats, right? You can't be like eating a bunch of sugar and then expect to last 16 hours, right? So, but it works. So it can work on its own through kind of restriction, but it really potentiates this fat metabolism that we're trying to achieve with low carb dieting, right? When you clear out that liver glycogen, you kind of further increase ketones, you further increase this appetite suppression. Okay, so I contend that ketones act centrally to inhibit appetite as well. So you want these higher ketones, and intermittent fasting can play into that. So in the beginning, there's no restriction at all. And in fact, it works really well for the binge eating types because you're giving them kind of ability to feel full, and they've felt shame and they don't want to eat and they don't want to, and then you're telling them it's okay. We want you to eat to your full. We want you to have a good relationship with food. We want you to get in touch with your appetite and satiety. And then when that happens, kind of neurohormonally, then we leverage we create a caloric restriction through intermittent fasting if it has not already created itself. A lot of times patients already tell me they're eating much less and the cravings are gone. Does that answer the question?
Yes, thanks. All right. Thank you, Dr. Troy. You've been very generous with your time.
Yeah. Yeah, anything else I can answer? We're good?
I think we're good.
Listen, I wish I could have been there, but, blame United Airlines. Don't fly United.